So now we're at the point where we got 3 data moonshots. By the way, how are we doing on time? We're good? All right. So then we may have time for questions, I guess. All right. So I got 3 data moonshots that I've come up with that I would like to see to reimagine the sort of global clinical research enterprise in the future of drug development. Moonshot number 1 is to establish a robust clinical research infrastructure in sub-Saharan Africa to expand access to investigational therapies by 2033. We'll talk more about that and why I'm saying that. Moonshot number 2, integrate predictive medication into routine clinical practice using clinical genomic RWE by 2033. And the last one, of course, again, my inspiration in Lori, advance the science of N-of-1 trials, single-person trials, using digital twin and responsible AI for drug discovery and development by 2033. How's that sound? That sound really good? All right, well then you guys can do it. I just come up with ideas. I don't actually do the work anymore. But let's talk about moonshot number 1, why I said this. Sub-Saharan Africa, believe it or not, represents 1.18 billion people. 2,000 languages spoken, 46 countries, and it's the second most populous region in the world. Now I'm going to take you through some facts, so you're going to follow me here. We're going to start up here. It's projected to account for 25% of the world's population by 2050. Life expectancy at birth, remember we said it was like 78 for the US right now. For sub-Saharan Africa, 61. Poverty head count ration is at $2.15 a day. They have recently, or at least it's supposed to be launching this year, their own regulatory body, which they've never had, equivalent to the EMA or the FDA, and they're calling it the African Medicines Agency, the regulatory agency for the African Union, and it's expected to be operationalized this year. Another thing you should know about this particular region is that a total of 2,861 clinical trials, or 4% of the global total of trials, were conducted in this region between Jan 2020 and December 2021. And roughly 50% of those are done in the following countries, as you would imagine, the more developed nations in that region: South Africa, Nigeria, Uganda, Kenya, and Tanzania. Now, I know you're thinking, you're like, well, they have problems over there, right? That's how you're all looking at me with the skepticism. I feel it. And I'm going to acknowledge it. So it's there, right? We're over there. Some countries may not have established regulatory agencies like the FDA or the EMA. We know that. Some countries don't have the infrastructure, whether it be facilities, staff, technology, supply chain. We recognize that. Clinical trial sponsors have been less likely to fund trials in this region. That's a problem. And then, of course, there's ethical concerns with trials, specifically the exploitation of the vulnerable populations in this country, which goes back to the ethical issues and the consent issues that we were talking about earlier. But there are benefits to doing this in this country or in this region, on this continent. There's access to diverse patient populations. There's reduced lower cost of labor and equipment and facilities, increased recruitment potential with the large and growing population, improved health outcomes as participants have access to now to these therapies that they wouldn't otherwise have access to. And then there's an ability to build a research capability and train many of these healthcare professionals in that region so that they can treat this very growing and fast-growing population of folks. You guys still with me? You think this is feasible? Again, do it. Now, this time you say, no, I don't know about that being feasible. Now I'm starting to get the reality. Okay, that's why it's a moonshot. Second thing, integrate predictive medication into routine clinical practice using clinical genomic RWE by 2033. This is my theory. We take care of people from the cradle to the grave, right? We do now have the ability to sort of create longitudinal records of patients because now we have all the digital technologies to do it through our electronic health records and other platforms that we use. What we must do is actually sequence their DNA at birth. Yeah, some people are like, oh my gosh, I don't want my stuff sequenced. But that's where the benefit of clinical genomic information becomes valuable, because now we know what works for you and only you, or even patients that look like you. So that's something to do by 2033. And then, of course, this advance in the science of N1 trials in honor of Lori Becklin by using digital twins and AI was not discussed as common technologies when she wrote her article. But the idea of creating a digital replica of each of us and then essentially doing in silico experiments where you're trying these therapies in a sort of in silico environment and you're not exposing the people is actually, to me, the ethical thing to do. And then you can actually simulate, if you will, how patients actually respond to many of these. Are you guys following me still? Can you do it? I'm getting a lot of that. The yeses are minimal now. What happened to the excitement? All right. So here it is, call to action. I'm asking each of you, your entrepreneurs, your intrapreneurs, your policymakers, your administrators, your professors, your whomever you are, I don't care. If you contribute to the system, this is an official call to action to each one of you that I need your help in order to achieve these moonshots, as well as address many of the other issues that we have in this healthcare system. The quote you see up here says, just do nothing. And then the other says, it is impossible. But if you read it all the way through, just do it. Nothing is impossible. That concludes my talk. Sure.
So folks, if anyone has a question, they want to walk to either of the microphones, please do so.
Good.
We have time for a few questions.
It's a great presentation. Thanks so much. It was a great overview. I have a couple of things that came to mind amongst the many. Yeah, a couple of things that came to mind. One of the last points you mentioned, sequencing the DNA all the way from birth to the end.
Yeah.
Which we all, as I'm a provider and I'm also on the hospital side and all of that. The biggest fear that I feel, that a lot of people also feel, that is if that information is not protected, which we hope it is, the payers dominate the landscape in the U.S. healthcare system. And the fear is if they get their hands on some of this information and they still we know they control the healthcare market, what will they do with it if they do get it? And that's a lot of people think that way. Maybe as the generations come up, they might feel more secure about that information getting out there. So I think that's a fear, because the payers are definitely an issue here. And then the other part is probably another discussion, is why is it that the U.S. healthcare system is so siloed, and why is it that there's such resistance to change? And we wouldn't see that as much on the business side in the private sector as there is in the public sector sort of hospitals, whether they're nonprofit or profit. And why is it that culture is so difficult to tackle?
Yeah. Well, the first question around the ethical concerns with DNA, the privacy issues, is fair. And the other sort of group that I would add in addition to payers is employers. And any other group that can effectively discriminate against someone because of their own health status. I think that many of the ethical frameworks that you see here are really meant, and they're sort of being constructed to address that. You got to raise the education level of folks of what is possible, and that no, you cannot do this. Then you have to hold them accountable to it, right? And that's what I appreciate what the EU is doing around this issue of developing ultimately public policy around what you can and cannot do with an individual's health data, as well as utilizing AI technology to enable that. So I think that the interesting dynamic that we always have is that public policy cannot keep up with the pace of technological advancements or scientific advancement. So I do think that it is a legitimate concern, hence my reason for it as a moonshot. But I think the benefits to me outweigh the negatives, the cons, right? Because I mean, what we're essentially doing is personalizing therapies now to individuals based on their DNA. And once you do it once, you only need to do it once. You don't have to continuously sequence a single person's DNA. And I think that once we have that, then you'll find that the benefits definitely outweigh the cons. But the payer concern, the employer concern are all very legitimate.
Right, and when that model changes, if it does, then we'll feel much more secure about doing the medical side of it. Is there's not even a question about it, you know, in terms of outcomes, and then the culture of the healthcare system in this country.
That's a tough one. It's perverse incentives. So I would say, honestly, there hasn't really been the incentive structure has not been, I'll say, up to snuff, if you will. To sort of incentivize that level of change and transformation. But that's transformation in any organization, industry, or in this case, our healthcare system, right? There's so many parties who benefit from the status quo. And it's not until you see that level of rise, almost like a groundswell of people who are demanding that level of change. Hence, when I had in the slide, precision therapy will be driven not by any particular institution or organization, but by patients demanding, just like Lori did, that you give me therapies that you know work for me. I don't care about what works for the masses, right? And so that is the world that we're going to get into because, honestly, you can do it. It's just a matter of people being made aware that it's possible.
Great. Thank you.
Hey, Angel.
One of the things that I think we've been able to see is more of a long-term perspective for patients when we're thinking about trying to capture and quantify the value of interventions and therapies for patients. We're also thinking about where in the patient journey do we initiate that prevention piece, or can we start thinking about screening and those sorts of pieces.
Yeah.
So I'm curious from your perspective, if you want to share, like, I guess, with the audience a little bit more about where you see the industry particularly pivoting towards that message a little bit more, and how you're integrating it into some of the programs that you oversee as an executive in that space.
Yeah, I think prevention and I will say early detection are keys. I mean, I think that a lot of the messaging, I mean, and you're sort of tapping into a number of things when you ask that question. I mean, I think part of it is this issue of social determinants, which we now recognize as a fully a real issue. And so hence the partnership between those two sectors within the field. And the whole, like, I know many of you have heard it, what your zip code tells you more than your genetic code, that whole theory, which is very much very true. And so I think that, you know, it's interesting from a biopharma perspective, the assumption is that you want the world to stay unhealthy because you make more money. Is that what people think? That's fair. But no, it's not fair. I don't want people to stay unhealthy. I don't think that that's true at all. I think that the world is starting to move to this space where we recognize that prevention is certainly one way, as we talk about the chronic conditions, which has been a big thing. Some diseases are unavoidable, whether they're genetic, whether they're just acquired because of the environment that you live in, however that works. But I think that what I'm seeing the world shift to is we're saying that there is more rare disease, which is not necessarily true. It's back to what Lori said. It's just individuals and your own disease state, your own environment, your own genetics, your own family history, your own nutrition levels. All these things become increasingly important. And the more we can educate people about the smoking, the diets, the exercise, the active living, these sorts of things, the better off that we will be. And I think that now, with that partnership between sort of the social public health agencies and many of the acute care facilities and docs in these local communities is important, because it used to be that the relationship between a patient and a doc was very paternalistic, right? You just do as I say. You come in, feel something, do as I say, go off. Now it requires, even when I go see my doc, I'm giving him as much information about myself and actually proposing alternatives, which he may or may not like, more so than we've ever done before, because I know my own health status. I know what I'll actually be compliant doing. I also know where my situation, and I think that's the case for a lot of people. The ability to be able to sort of self-advocate or advocate on behalf of your loved ones is the new sort of medication that we all need, right? And that is education and awareness.